everyone to Smarter About Medicare, our third segment in our Smarter in September series. I'm Kelly Robert. I manage the Journey program at UBT, and Journey is designed to bring opportunities for education, enrichment, and entertainment sometimes to our customers and their friends who are 50 and over. And a huge part of Journey is, of course, education. And education about Medicare is something that people frequently ask for. Jonathan and I were chatting about what a huge topic this is for people. So today's presenter, I'm just really excited to bring him to you. It's Jonathan Burlison. And Jonathan is the administrator for the Nebraska SHIP or SMP division. And you're wondering who that is. He serves as the administrator for the Nebraska State Health Insurance Assistance Program, a division of the Nebraska Department of Insurance. Jonathan joined Nebraska SHIP in 2017 and was previously the program's outreach coordinator and regional representative, coordinating volunteer activities within the southeast portion of Nebraska, accepting the role of program administrator in May of 2022. Jonathan finds great fulfillment in his role as he continues growing the program and providing local help for Nebraskans with Medicare. And I think you'll find as he starts talking that he really knows his stuff. You're just not going to believe all of the nuances that he's going to share with you. So Jonathan, thank you so much for joining us today, and I'll just let you take it away.
Perfect. Definitely. Happy to be a part of this activity, Kelly. Always a wonderful opportunity to share education about Medicare in partnership with you and the wonderful folks at Union Bank. So appreciate the opportunity to be here today. As Kelly indicated, my name is Jonathan Burlison. I do serve as the administrator for the Nebraska SHIP and the Nebraska SMP. If you have not heard of the program SHIP or SMP, let me provide you a brief review of who we are so you understand who is providing today's education. So the acronym SHIP, as Kelly shared, State Health Insurance Assistance Program. What the program is it's federally funded by the ACL, the Administration for Community Living. That federal funding provides us the opportunity to provide unbiased and confidential information on the topic of Medicare. The SMP office, also federally funded through the ACL, Senior Medicare Patrol, the acronym stands for. What that provides us the opportunity is to educate individuals on that topic of preventing Medicare fraud, error, and abuse. And we also serve as a location for folks to be able to report suspected Medicare fraud, error, or abuse. Definitely both programs do a significant, or rather provide a significant function in the state when it comes to learning about this very complicated topic of Medicare. And as you'll learn as we progress through the next 60 minutes, this is a topic that does see changes on a regular basis, and those changes are something that folks need to be aware of in order to make the most effective decisions regarding their health care when they do progress into the Medicare program. Now, certainly I do encourage questions. Questions means you're engaged, or maybe I'm not covering something that you need to know about. So please do ask questions. Depending on timing, we might hold for questions at the end, but if something seems relevant, certainly we can go ahead and interrupt at that point, Kelly, if we need to. Definitely, I am very flexible and don't really mind if we do interrupt for a quick question. So please do ask questions, folks. I believe Kelly has indicated you can chat those in through the chat feature. So more about the program before we move on to the topic of Medicare. Because of the federal funding, there is a SHIP and an SMP in all 50 states and U.S. territories. So if you like the information you're receiving from Nebraska today and perhaps have friends or family who reside in other states, there is a SHIP, there is an SMP in all 50 states and U.S. territories. That's what that federal funding affords the program to provide. Now, the 800 number shown on the screen, that is an in-state within Nebraska hotline for folks to reach these several office locations that do exist here in Nebraska. Our website certainly does provide some great information regarding the Medicare program. But again, if you do have interest in seeing what other SHIP programs in other states, seeing their contact information, you can reach out to our office, or you can go to shiphelp.org. That's shiphelp.org. So just a reminder that the Nebraska SHIP and SMP federally funded to provide unbiased education on this topic of Medicare. We're not here to endorse or promote insurance companies, products, or individuals. We are here to educate. So the topics that we're going to cover during the next few minutes will be these topics. What is Medicare? A quick review of the parts of Medicare. And then we're going to dig into the 3 C's, those considerations when making decisions regarding your Medicare options. We're going to dig into the Inflation Reduction Act and what that particular law has done to the Medicare program and the different considerations you will need to take into account because of the changes based on the IRA. And then I'm going to demonstrate how to use the Medicare.gov website, specifically the Medicare Plan Finder, so that you can see that the tools that Medicare makes available to you are very easy to navigate. And really, if you're doing research yourself, Medicare.gov, gov.gov is that official website that folks should rely upon for unbiased, complete education regarding what options do exist. So we're going to cover a lot of information very rapidly and quick. Definitely the biggest takeaway is just to remember that you do have the SHIP and SMP office to help you individually. So if you're trying to jot down notes and I'm going a little quickly, ask questions or remember to contact our office at your convenience to pursue further explanation of your specific questions. So what is Medicare? To put it simply, it's federal health insurance. It was created in 1965. President Lyndon Johnson was that individual who signed this into law. At that point in time, though, Medicare was only provided to folks who were 65 years of age or older. It wasn't until 1972 that Medicare was expanded to include coverage for these other 2 groups of individuals, those folks with a qualifying disability being younger than the age of 65, or those individuals with end-stage renal disease, which is essentially permanent kidney failure. So in order to qualify for the Medicare program, a person simply needs to fit into one of these 3 categories. Once a person enrolls, the Medicare image shown in the corner of your screen, that is an image of the current Medicare card. Briefly, note that this card is paper. There are fraudulent phone calls that are being reported in Nebraska as well as throughout the entire U.S. that there are people claiming to be with Medicare that are offering plastic Medicare cards. The offering of a plastic Medicare card is a fraudulent phone call. If you receive one of these phone calls, we encourage you to hang up. Don't engage. It's okay to be rude. These folks are trying to get your personal information so that they can work their nefarious ways, and definitely we don't want folks to be victims of fraud or abuse because they were tricked into providing their information. And that offering of a plastic card is definitely one of those effective tricks that the scammers are using. So remember, Medicare, the red, white, and blue card, it is a paper card. Now, moving beyond that, when a person becomes Medicare eligible, visually what we're showing you here is typically folks have two options in how to receive Medicare benefits. The first visual, original Medicare, we're showing you that there are potentially four individual parts that can make the original Medicare structure. Now, depending on your individual situation, you might need all four parts of the original Medicare structure to have complete rounded out coverage. Potentially, you may only need two parts of Medicare, of original Medicare, potentially just the Part A and Part B, especially if you have access to other types of insurance, perhaps a retiree plan that offers as a secondary payer and drug coverage, or perhaps you have access to the VA and are able to obtain prescriptions through that source. So definitely, we do encourage folks to remember that Medicare is individual insurance. You're going to be making decisions based on your individual needs. And remember, what works well for friends and family, potentially it's not going to work well for you. It is an individual decision. Certainly, the visual you see, the alternative to original Medicare, is that structure of Medicare Advantage, which effectively combines Part A and Part B into one package. Typically, Part D drug coverage can be included within this package as well, serving as one of those extras. We're going to dig into this a little bit further. But visually, again, potentially one of two options. Enrollment in the state of Nebraska with regard to these options, you do see that we have 379,000 individuals in our state who qualify and are currently enrolled into the Medicare program. Of those individuals, 66% of Nebraskans with Medicare have opted, to receive their Medicare through the original Medicare structure. Now, that doesn't mean all 250,000 of these individuals have a supplement and a Part D, but they at least have Part A and or Part B medical insurance. Now, we see alternatively, those folks enrolled into the Medicare Advantage plan were at about 34% of enrollees receiving their Medicare through that structure. This information is effective as of March of this year. Certainly, these numbers probably have fluctuated since then, but I'm guessing not significant. So the last point that we were making here, folks, is certainly you are seeing the enrollments within the state of Nebraska between these two options of original Medicare versus Medicare Advantage. Nationally, the numbers are actually a lot closer. We do see 49% of individuals nationally in the original Medicare structure, the other 51% in the Medicare Advantage plan structure. So nationally, we are seeing that scale tip towards that Advantage plan structure, whereas again here locally within our state, the majority of folks are receiving Medicare through the original Medicare structure. Very interesting data that might play into some of your decision making if you are looking at the differences between these two options. Now, beyond that, what does my Part A do? Well, Medicare Part A is your inpatient hospital insurance. In fact, only covering these four items listed on the screen: inpatient hospital care, skilled nursing, home health, and hospice. Now, when you see skilled nursing, don't confuse that with a move into a nursing home. Remember, Medicare does not pay long-term care cost, like most insurance. Essentially, when you see skilled nursing, that's more of more along the lines of a rehab stay. Perhaps the person's receiving physical therapy or speech therapy. That's what skilled nursing care is alluding to. Now, we do see on the slide that your Part A is typically premium free. 99% of Medicare eligible folks do qualify for premium free Part A. How you earn premium free Part A is 10 years of employment, 40 tax credits. As long as you've worked 10 years in your life and earned 40 credits, you have earned premium-free Medicare Part A. That said, if you do need to use your Part A, there are costs associated with that use. $1,632 is the deductible for inpatient hospitalization this year of 2024. Certainly, this is a deductible that can be seen more than once within a calendar year because it's based on a benefit period. So depending on a person's health, they could pay this $1,600 deductible once early in the year year, maybe around spring, and then maybe later that year their health requires another inpatient stay, requiring another $1,600 deductible. Definitely costs can accrue quite rapidly with the use of Part A, although premium free. You do see the examples of daily copays associated with needing care beyond 60 days or in the event that you're accessing the skilled nursing facility care. Note that these copays and these deductibles can increase from year to year and typically do. That information is usually provided in late October, early November, so I'm not going to have that preview of 2025 for you yet. With regard to Part B, the medical insurance, think of Medicare Part B as being the part of Medicare that you potentially use the most if you use your health care, essentially paying for everything outpatient that's medically necessary, keywords in the world of Medicare and health insurance in general. Now, as far as cost, Medicare Part B does have a standard monthly premium. It is $174.70 per month. Folks who have a higher income will potentially pay more for their Medicare Part B premium based on their modified adjusted gross income on their tax return from 2 years prior. Now, if you're a person who has higher income, the way you're going to learn about this is through a notification sent to you by the Social Security Administration. That letter is going to say what they use to determine whether or not you're eligible for an IRMA, how much extra you're going to pay, but it also includes instructions on what you can do to appeal this decision. Life-changing events, perhaps loss of income through retirement, that is something that can potentially reduce or eliminate the IRMA based on, again, your individual situation. Now, outside of the premium, certainly there is a deductible, one-time annual deductible of $240. Once you've paid that deductible, you then start sharing your costs with the Medicare program at the 80-20 split. Unfortunately, your 20% has no limit on spending. It's 20% of $1,000. It's 20% of $100,000. There is no limit on that. That's certainly where a Medicare supplement would come into play, and we'll of course talk about that here in just a moment. Briefly, with regard to enrollment into Medicare's Part A or Part B, typically the first opportunity to do so is during what's known as the initial enrollment period, whether it's at age 65 or if a person is qualifying based on disability on the 25th month of receiving disability benefit. Certainly, if a person is working beyond age 65, maybe they're waiting for full retirement, age 67 and 4 months, or whatever it happens to be. At that time of retirement, a person has access to a special enrollment period. Now, do note that this only exists if that person has been insured through insurance from active employment, whether it's their own employment or perhaps it's their spouse's employment. So that really is the only type of insurance that allows for that enrollment and actually avoids Medicare penalty. And again, that's insurance from active employment, a person's own or their spouse's. If a person were to miss initial enrollment when first eligible, and if they miss special enrollment at retirement, the only other opportunity to enroll into Part A and or Part B is during that first quarter of the calendar year, known as general enrollment. Definitely a person who is enrolling during this time is potentially needing to have that further conversation of Medicare penalty. Certainly Medicare's penalty is lifetime. You pay an additional amount every single month for the duration of being enrolled into the Medicare program. So simply, in order to avoid Medicare's penalty, enroll when you're first eligible unless you have insurance from active employment. Now, moving beyond that into Medicare supplements, remember that this is optional, this is extra. A person is not required to purchase a supplement. Should they decide to do so, what they're doing is they're purchasing a policy that is designed to pay for their out-of-pocket expense after Medicare Part A or Part B, the hospital or medical insurance has paid first. Now, premiums in Nebraska do have quite a significant range, anywhere from $35 up to $640. This is not an exaggeration. An example of a $35 premium that would be seen if the individual were a 65-year-old female non-tobacco user looking at a high deductible Plan G option. For a $35 premium, this person is obtaining a supplement that has a $2,800 deductible. Once that deductible has been met, the supplement kicks in and starts paying 100% for those line items that it's designed to cover. So truly, a person does have flexibility in the level of coverage that they can elect through a Medicare supplement. The biggest takeaway regarding Medicare supplements is potentially this information. Remember that a person has a guarantee issue, what's also known as a Medigap open enrollment. It is a 6-month window that starts when a person starts their Part B medical insurance for the first time at 65 years of age or older. During this 6-month window, a person cannot be denied a policy. They cannot be charged more for that policy either based on pre-existing or current conditions. They are guaranteed the policy at the low, fair, healthy rate. Now, certainly anytime after that 6-month guarantee issue, a person can shop for a policy at any point during the calendar year. But what does need to be considered and remembered is the fact that underwriting will have an impact at that time in the future. Underwriting will determine whether or not that policy is offered, and if so, how much they're going to ask you to pay for it. So because of that, one is encouraged to really think of the Medicare supplement as being potentially a lifetime decision, especially if an individual has a current or pre-existing condition that underwriting would not view favorably in the future. So Medicare supplements, an important part of the original Medicare structure if you choose to purchase one. Moving on to Part D, probably the little more of meat and potato that we were looking for with regard to this topic. Medicare Part D is prescription drug coverage. It was introduced in 2006. So definitely we see different parts of Medicare being introduced at different times. A significant addition to the Medicare program, what Part D does is it offers coverage of brand name and generic prescriptions. In our state this year, 22 plans exist, with 21 of them able to enroll new individuals as new enrollee plan members. The premium range, that is not an exaggeration. There is a difference of $123 between the low end versus the high end, and certainly IRMA can be imposed on this part of Medicare as well. Those folks potentially paying more for their Part D drug premium as well. Again, it's an appealable process, and we encourage that appeal if a person believes it's warranted. Outside of that, the Part D plan can have its own deductible, the maximum this year, $545. And certainly a person would encounter both copays and or coinsurance depending on their individual needs. So Medicare Part D, it is definitely a part of Medicare that you don't want to sleep on. This is a part of Medicare that you do need to have an awareness of moving forward. And certainly the enrollment opportunity, we do see kind of that pattern of the initial enrollment or the special enrollment if working beyond age 65. But do note that there is an annual opportunity to evaluate coverage for next calendar year. Remember, these plans do work on a 12-month cycle, being the calendar year, and they can make changes, whether it's changing their name, their premium, their deductible, or even their formulary, that list of drugs that they cover. So we are approaching open enrollment, and anyone attending this now who is currently enrolled into Medicare, certainly do take note that this is an opportunity that you should not, again, sleep on. You do want to have a conversation to make sure you are receiving the best coverage for your dollar in the next year. Moving on to the Advantage plan structure, remember that this is the alternative to the original Medicare structure. Essentially, a person enrolled into this option is effectively choosing to have their Medicare managed by the private insurance company that is managing the program. It is required to provide equal coverage as that provided by the Part A and the Part B. Typically, the extra coverage, as I stated previously, is coming from the inclusion of drug coverage at no additional cost. But you do note that many of these plans will offer access to dental or vision or hearing on a routine basis. Why this is attractive is because the original Medicare structure, it does not cover those line items on a routine basis. So the example I typically give is if a person is like me and they need corrective lenses to legally drive, that's not medical necessity. The Medicare is not going to pay for that. That's where this Advantage plan says, hey, let's go ahead and kind of lump this extra into the package as that enticement, if you will, to opt to have your health care managed in this structure. Now, certainly you do see on the screen that there is one county in our state of the 93. 92 have an Advantage plan. The lone county of Cherry itself, unfortunately, is without this option, at least in this calendar year. That potentially may change in the future. We don't know yet. The other thing to consider when you are looking at Advantage plans, and the major thing to really keep in mind, is the fact that this is going to be a network structure. Typically, you're going to encounter HMOs or PPOs, but there are these other structures of a PFFS or a cost plan that you may encounter depending on where you reside within our state. But again, primarily HMO and PPO are the most prevalent options. And the simple difference between the two, and HMO is a network use only. Going outside of that network requires you to pay 100% of costs typically. And also, in order to see a specialist, you do need a referral prior to doing so. Whereas the PPO, there is more flexibility there. There is a network that if you can maintain it, lower cost, lower copays, but there is that access to out-of-network coverage if the out-of-network provider is willing to accept this type of insurance. And as far as the specialist is concerned, there is no need for a referral to see an individual in that profession of a specialist if that is something that this person is needing to seek out. So really, access to care is what we're talking about when we talk about networks. Is this something where I need to ask for a prior authorization, get permission before I see a specialist, before I receive an inpatient or outpatient procedure? Those are the things that you really do need to be taking into account when you're making these decisions as far as, am I going to be covered by original Medicare, or am I going to be covered by the Advantage plan structure? So there's some homework for sure. Now, the other thing to consider with regard to the Advantage plan is that potential cost. I'm sure we see those commercials where the commercial screams at us that we get our Medicare plus dental and vision and maybe access to over-the-counter benefits, and it's all free. Certainly, we know that there is no such thing as free. The relationship between the Advantage plan and Medicare, essentially Medicare pays the Advantage plan a monthly amount in order to assume the risk of providing insurance to the individual who enrolls. So Medicare is paying the Advantage plan ahead of time to assume that risk. If you have claims, well, you are making claims against the amount that was paid to the Advantage plan on your behalf. And certainly, you, depending on what you're receiving, you might be, using a little bit more of everybody else's funds. Just everything's going into a large pot, if you will, and they pull from that pot as necessary. You do see the examples of the copay structure within the Advantage plan on this slide. Maybe it's a $5 or $10 copay for that doctor visit, $45 or $50 for that specialist, etc. This is the pay-as-you-go structure. You're paying for services as you receive them. Note there is no supplement option to help with this out-of-pocket cost. It is your responsibility until you hit a limit on spending, noting that on the screen, that limit basically sits between 2,500 up to 13,300 within the PPO structure. So your spending is going to be different. It's an option that can be viewed sometimes as maybe cost effective for a person who has a lower use of their insurance. Maybe they're healthier and only really pay for services as they're received. That's where one may find this option to be cost effective. Whereas a person who has a higher usage of insurance, they may potentially find the original Medicare structure to be the more cost effective option. Again, individual insurance. Moving beyond that, enrollments, very much that theme, initial enrollment at first eligibility, special enrollment upon retirement. But note that special enrollment can be created through other life-changing events. Maybe a person starts out in Nebraska, gets tired of the icy winters, and decides to move south. That relocation, that move out of the area creates a special enrollment to evaluate and pick something new if something different is going to serve better. Certainly, we see that there's the annual open enrollment coming up this next month, but the Advantage plans also have an additional open enrollment period that first quarter of the calendar year. So effectively, a person could enroll into an Advantage plan and give it a try in maybe the month of January and February. And if they figure that they like it, they can remain in it. But if they don't, they have until March 31st to make a change, and that's either moving into a different Advantage plan or maybe returning to the original Medicare structure. So there is flexibility. You do have things to really consider every year, especially if saving money is a part of the decision making that you're looking at. How am I effectively using my insurance and not paying for more than I need to? Those are things that, again, you're probably taking into account. Now, certainly there's that question about next year. What about next year? You're telling us about 2024 and the year is almost over. Certainly, if I had that information, I would have gladly would have been providing it. But unfortunately, the Medicare program, they don't release information for the Part D or Advantage plans until October 1st. And as I stated, for Part A and Part B, typically not till the end of October or within those first couple of weeks of November do we learn about those changes. So we are all kind of on pins and needles in this office waiting for the information so we can rapidly create our training material to train our volunteers to serve folks in the state. So stay tuned, I guess, is the message here. So we have reviewed the Medicare program quite rapidly. And again, hopefully folks are hearing things that is important to them, learning something, maybe just confirming things you already know. But let's go ahead and move into that next section of the 3 C's. What does one need to consider when evaluating their options? And this is very specific to the Part D and the Advantage plan options, kind of focusing in on the drug coverage. So when it comes to the 3 C's and we're talking about drug coverage, one of the first things that I communicate to folks is the fact that Medicare does require the Part D drug plans or the Advantage plans that provide drug coverage to cover drugs within these protected classes or categories. Essentially, most drugs within these classes or categories are going to be covered by the plan. Regarding anything else not within these protected classes, typically plans will cover 2 to 3 of the most commonly prescribed drugs. So it is really important that a person really take into account that plan formulary. The other thing that you're going to encounter and need to be aware of are potential restrictions. Those restrictions can come in the form of prior authorization, step therapy, or quantity limit. Essentially, your doctor is probably going to be taking a hand in any request to forego a prior auth or a step therapy. Certainly, a prior authorization, as we note, it's basically the plan saying, no, we don't cover it, and it's paperwork from you and your doctor that says please consider covering it. And certainly that plan has the right to say yes or no. Step therapy, maybe you're prescribed a very expensive brand name and the plan says, yeah, we'll cover it, but first we want you to try the generic option first to see if that works. That's that example of step therapy. If you've already undergone that process with a previous insurance, then you can tap your doctor to do the prior authorization process so you don't have to go through the step therapy requirements. Quantity limit, just like it sounds, how many can I get within a given period of time? These are all things that you can see change from year to year. So even if you're happy with your current insurance, if you're currently enrolled into a Medicare drug plan, things can change. So again, you don't want to sit on it. Have a conversation, confirm that there haven't been any changes that can affect you. One of the things that you're also looking for if you are currently enrolled, in this month of September, drug plans and advantage plans are required to send you an annual notice of change. As well as an evidence of coverage. That documentation is essentially going to help you start this conversation to determine what is changing from this year into next. And that's, again, assuming you're currently enrolled in the program. If you're not enrolled yet, just note that when you do, September is the month that you get this information. Cost, the next C, certainly outside of coverage, is cost. What do we need to know and consider about drug coverage cost? Well, your actual drug cost is going to be really dependent on the prescription list that you have in place, assuming you do take prescriptions. If you're fortunate enough to not take prescriptions, then maybe you're just looking at that premium, that deductible to make your decision. But again, if you do take prescriptions, that should be the driving force behind your decision making. Definitely, the other thing to consider is where are you at within the Medicare coverage levels? Currently, 4 different levels exist. The first level is that deductible level. Potentially, you're paying $545 out of pocket before you progress into the second level known as initial coverage. Initial coverage, typically on a national average, the plan is paying 75% of the cost, leaving you, the individual, roughly 25% of total costs during this particular phase. Now, some folks, they end the year in initial coverage. Maybe they have generic drugs, and that's about it, just some maintenance drugs. But if a person does have prescriptions prescribed that are of higher cost, those brand names like a Xarelto, a Jardiance, a Brio, if you can pronounce it, it's probably expensive, essentially. A person could progress into what is known as the coverage gap or donut hole. We do see that the slide shows that amount of $5,030 is what pushes the person into the coverage gap. Now, that $5,030 is not strictly out of your pocket. That's out of your pocket during the deductible and initial coverage phase, and what the plan has paid during those phases as well. So it's that combined cost between you and the drug plan. Should you progress into the coverage gap this year, you have a 25% responsibility for all of your prescriptions. Now, certainly a person could progress out of that and enter the 4th and final phase of coverage known as catastrophic coverage. We see that that would be reached when a person has a true out-of-pocket cost of $8,000. Now, again, that doesn't mean that you are yourself personally spending $8,000. It's what you have spent during the deductible, initial coverage, and the coverage gap phase, and what the manufacturer of the drug pays for brand name drugs within the coverage gap. That's a lot of information, and it's kind of complicated, but that is really what a person needs to be aware of as they progress through these coverage levels. Should a person this year hit catastrophic coverage, they have a zero-cost responsibility, in effect capping their cost. That cost cap sits anywhere between $3,000 to about $3,500, depending on the drugs in question that the person is prescribed. So Not only is it a question of my prescriptions, whether or not they're covered by the plan, at what tier level are they covered, but where does a person sit within the coverage levels? Those all have an impact on a person's out-of-pocket cost. Additionally, the third C, convenience. Convenience is another factor that affects your out-of-pocket spending. When we say convenience, what we're referring to is that network of the plan. You typically do see access to preferred pharmacies, standard pharmacies, or just out-of-network pharmacies in general. Typically, a preferred pharmacy is going to fetch you the best lower out-of-pocket cost. So we do encourage you to compare more than one pharmacy when you're having a conversation about your plan options. Now, certainly the Inflation Reduction Act, as I indicated, is going to be a topic, and that's where we are now. We've progressed into that portion. The Inflation Reduction Act signed into law in August of 2022. It has had an impact on Medicare drug coverage and will continue to do so through the remainder of the 2020s. With regard to the first change that was seen, we note in 2023 the $35 limit on a 1 month supply of insulin was imposed. Essentially, prior to this, a person with insulin dependency could pay hundreds of dollars just to maintain their health. Now, as long as the plan covers the insulin, it's on the plan's formulary, a 1 month supply would only cost the individual $35. This year, as indicated, the cost responsibility within catastrophic coverage has been eliminated. And notably, next year in 2025, we will see a $2,000 spending cap. You will not spend more than $2,000 on your Part D prescription drugs in the year 2025. And then, of course, in 2026, we'll see the introduction of the negotiated drug cost for specific medications. We're going to see those medications here in just a few minutes. So this visual looks a little familiar, but note the big red X. Essentially, what we're finding is that we will still have a deductible phase. Next year, potentially $590 is going to be that maximum deductible for the plans. Once the deductible is met, again, initial coverage is what a person would experience. Again, potentially the plan is paying the majority of the cost, about 75%. At a certain point, a person will not need to worry about the coverage gap. The coverage gap is being eliminated. It will no longer be a factor starting 2025. Essentially, a person, once they hit that $2,000 spending limit, they enter that catastrophic coverage, at that point being the third and final phase, and they would have a zero cost responsibility for their prescriptions during that time. So the Inflation Reduction Act is going to be making this change quite immediately moving into the next calendar year. And if you are looking at becoming Medicare eligible next year, this is a significant change that you should be aware of and maybe potentially thankful for, that the coverage gap was not something that you needed to worry about. Again, assuming you're starting Medicare next year. If you're a person currently with Medicare and have higher drug costs, you probably are familiar with the coverage gap. But again, next year moving forward, not going to be a factor. The other thing that the Inflation Reduction Act is going to do potentially is change how a person is able to obtain their prescriptions. Note that current law basically mandates that a person has to pay for their drugs at the pharmacy counter. Next year, because of the Inflation Reduction Act, we are going to see a change in that process. It is going to be a voluntary program known as a Medicare prescription payment plan. It is voluntary. In order to join the prescription payment plan, you will need to opt in or sign up yourself through your Part D prescription drug plan. Now, certainly some things to keep in mind regarding this new program. Medicare does ensure that all of the plans are using the same calculation process in figuring what the payments would be for essentially the program. Basically, what is going to occur through this prescription payment plan is it's intended to essentially spread the $2,000 cost responsibility out during the 12-month period, 12-month calendar period, essentially. So the example of maybe a person is prescribed the high-cost brand name, maybe it's the Jardiance, and we have a plan that has a $590 deductible. Well, instead of paying that $600 at the counter that day, if a person is enrolled into this plan, this prepayment plan, basically they get to take the drugs home for free that day. The pharmacy will still receive payment from the plan, what they're due, and then the plan will bill you, the individual, for your drugs, again, spread out during the calendar year. The intention is to essentially not have a person have that very high cost out of pocket at the beginning of the year. Instead, again, smoothing that out and allowing for potentially smaller equal payments to satisfy the $2,000 spending limit. Note that the plans are not going to be able to impose late fees or interest payments or any other kind of fee with regard to this payment plan. And certainly there is guidance that's being provided right now. Anyone who is currently enrolled into Medicare drug coverage, if they have had an expense of $2,000 or more for their prescriptions, their plan will be sending them information this month indicating that this repayment program is going to be made available next year. And if a person decides that they want to enroll into it, we do see that the plan will have 10 days to process that application rather. Excuse me, I was getting an itch in the throat. Now, if a person were to enroll into this repayment plan next calendar year, once the new program year has started, we do see that the plan is required to process that application within 24 hours, reducing that impact on an individual from potentially not getting their prescriptions. So it is definitely a significant turnaround, and it is a lot of responsibility that Medicare is putting on the plans. Note that unfortunately your pharmacist cannot help you do the enrollment. It is a process that you would need to complete yourself by directly contacting your plan. So your pharmacist won't be able to help you enroll, but that said, the pharmacist has been asked to provide awareness of this program, specifically if a person goes to refill their drugs and if that refill cost is more than $600 or more, the pharmacist is asked to communicate to the individual, you might potentially benefit from the repayment plan. So who does potentially benefit? It's again that person who has the high cost medications at the beginning of the year. A person who would not benefit potentially is that person who's maybe just prescribed maintenance drugs, very low cost generics. That would be a person who probably would not see enrollment into this program as beneficial. Now, certainly it is voluntary to opt in and a person can voluntarily opt out. But there is that instance where a person potentially is involuntarily opted out due to their inactivity of paying their bill. Should a person decide to simply not pay their bill, the plan does have that opportunity to disenroll a person from the repayment plan, but that disenrollment does not eliminates the insurance coverage itself. The person still has the insurance, they've just been removed from the repayment plan. Now, because we do anticipate that that can be a factor, Medicare has put some guidance into place. They do ask the plans to provide at least a 2-month grace period for folks to be able to right the ship, if you will, and show good cause, show that they will be paying their bill essentially. So it is something something that Medicare has thought through. Hopefully, they've addressed most of the potential situations that can occur, but essentially it is new. So we will be seeing Medicare work through this process as it is introduced, and potentially some changes may be necessary. But hopefully they've thought of a lot of the things that need to be thought of in order for this program to be successful. Moving on to that 2026, this is just a quick look at those drugs and what we are seeing as the price negotiation. This information is something that you can find on CMS's website. I did borrow this clipping from the CMS website in order to share this information with you. But basically, you see that it's those drugs that you can pronounce: Januvia, Farxiga, Enbrel, Jardiance, Stelara. We do see a significant reduction in those negotiated costs, though. You see that column showing basically between 66 to just shy of 80% in negotiated discount for these prescriptions. Those final remainder drugs, again, quite similar. Imbrucana, Entresto, Eliquis, Xarelto. Again, we can pronounce it. It's probably expensive. So these new prices will be something that are seen starting in that calendar year of 2026. There will be a new line of drugs that will be suggested for negotiation for 2027. They have not released that list yet. So more to come. Definitely we'll see how this works out, and hopefully it pans out well and we don't see a lot of pushback or plans making adjustments like increasing premiums significantly, etc. We're all going to learn how this process turns out together, essentially. So we've progressed to the portion where we can provide a quick demonstration, and I know we started a little bit later, Kelly, so I will not take up hopefully more than 10 minutes to just at least give us a view of the Medicare.gov website. But before we do that, are there any questions to address?
And Jonathan, that is just fine. You take your time. I think everyone is willing to stay on and hear what you have to say. And I have one question in the chat feature. Okay. Do you have to sign up for Part A in order to start a person's Social Security?
A good question. The answer is no. So, excuse me, I hesitated there for a second. So essentially, when it comes to Medicare and Social Security, you can opt to enroll into Social Security and not start. Excuse me, I'm going to correct myself. Just because I've been talking a lot this week, I just want to make sure I'm saying this correctly. So when it comes to Medicare and Social Security, a person can elect Medicare and not enroll into Social Security benefit. Perhaps a person wants Medicare health insurance, but they're waiting for full retirement age to collect their full Social Security benefit. As soon as a person enrolls to receive Social Security cash benefit, you must, at the very least, enroll into Medicare Part A. That is the basic requirement once you start collecting Social Security cash benefit. So if we have a person who has that situation of maybe they said, well, I'm 62, I'm going to go ahead and start collecting my Social Security, that is a person who would be automatically enrolled into both their Part A and their Part B hospital and medical insurance. That person has a decision to make. Do they keep the Part A and Part B and start paying their Part B premium? Or are they a person who maybe has access to insurance, maybe through their spouse? Maybe they married young and their spouse still has another 5 to 10 years of employment and access to insurance in that case. Well, certainly a person would have that opportunity to say, wait, I want to wait on my Part B, send that Medicare card back, effectively saying, I don't want my Part B. They would then receive a new Medicare card that would say Medicare Hospital Part A only. So again, you don't need to start. You don't, excuse me. You don't need to start your Social Security if you want your Medicare. But if you want Social Security, you have to take Part A at the very least. Hopefully that made sense. Sorry, I'm stumbling over my words for that question.
Not at all. Kathleen, let me know in the chat here if that didn't answer your question. The second part of that I think that Kathleen had is if I just have yes, if I just have part A, do I need to fill out something every year? Like you pick something for part B and part D, and I think you answered that as
Yeah,
you
good
were.
question. Let's just address that. So, if you are a person who is not wanting to enroll into Medicare yet, say you're 65 but you're still working, there is no process to tell Medicare or Social Security that you're not interested in enrolling. Basically, what happens is in the future when it does come time to retire and you decide it is time to enroll. One of the forms you're going to fill out is called the Request for Employment Information. You will fill out Section A. Your employer is going to fill out Section B. And what your employer is providing is your employment dates and your insurance dates. It's that form that will negate any potential accrued penalty. So definitely that's what would be required at that time. Again, you don't have a process to complete letting Social Security, Medicare know, I'm not interested yet. Good question.
Great. Thank you. And Kevin has a question. Hi, Kevin. Why is Nebraska Medicare Advantage so much lower than national average?
As far as the enrollment, that's a good question. So one of the things that we would need to take into account is the fact that we live in a very rural state. There are miles upon miles between us and the Panhandle. I was sharing with Kelly before the webinar started that I was participating in the Department of Insurance's roadshow, and last week our roadshow took us into Scottsbluff and Alliance. We traveled over 1,100 miles to be able to provide that education in the Panhandle and the northwest portion of our state. So really what we're looking at is accessibility to a network. Is there sufficient healthcare providers to build a network, and are those companies who sell the Advantage plans, are they willing to build that network within the rural community to exist and provide a plan option there? Typically we see in eastern Nebraska more Advantage plan options, which makes sense. You have the Lincoln Omaha Metro, and that's definitely something to consider in that as well. So it really is population and accessibility to a sufficient network is probably one of those factors.
Great, thank you. Kevin, you'll have to let me know if that answer wasn't sufficient, but I think it was very comprehensive. Keith wants to know if you can be denied coverage in an Advantage plan due to pre-existing conditions.
The answer is no. Medicare Advantage plans are required to allow enrollment for anyone who has both Part A or Part B, including folks with ESRD.
Thank you. And I just see one more here, and then I know we all really want to see that tool. And I know you're anxious to show it off. Deb asks if there are disadvantages of medical coverages if you enroll in the Advantage plans.
So, from an unbiased source, how I will answer that question is feedback that comes into our office with regard to potential cons of enrollment into an Advantage plan really comes back to that network structure and that that process of prior authorization. Now, that prior authorization process definitely is probably going to be seen the most when a person is trying to access skilled nursing facility care. For example, maybe a person is prescribed 20 days of skilled nursing care. Potentially an Advantage plan will say, okay, we acknowledge that you're prescribed 20 days. We'll initially approve 5, and on day 5, we'll take a look and have a conversation to determine whether or not we'll approve the next 15 days or any portion of those next 15 days. That process can sometimes be seen as a roadblock, if you will, to accessing one's care. Sometimes a person receives a denial and goes through an appeal process. Maybe they get denied again, they go through another appeal process, and then they get approved for receiving that skilled care. Well, that process can be lengthy and sometimes frustrating, not only for the individual who's trying to access their benefit, but for that treating facility who wants to get paid for providing services. The other thing that we're seeing within Nebraska itself, interestingly enough, we're starting to see hospital systems make announcements that starting next calendar year, they're no longer going to accept Medicare Advantage plans. An example of this is Great Plains Health in North Platte. Additionally, communities surrounding North Platte, Ogallala, Oshkosh, and Kimball, those hospital systems and those communities have also made that decision to no longer accept the Advantage plan beginning next year. One of the reasons they cite for this is because they are critical access hospitals. And essentially a critical access hospital, when dealing with an Advantage plan, that contract negotiation essentially provides the hospital a lower reimbursement rate than what would be paid from the original Medicare structure itself. So basically, these providers are saying, not only do we have to jump through hoops and combat prior authorization, when we finally do get paid, we're not getting paid as much as we would if this person had original Medicare. So we are really seeing a push by providers to really maybe perhaps create some leverage for negotiating a better reimbursement, or maybe they've just thrown their hands up and are just completely done. It will be interesting to see what 2025 yields, but at this point, it is something that you do need to be aware of. So if you are a person who is interested in Medicare Advantage, the homework I send people home with, contact your providers, your hospitals, anybody you want to maintain a relationship with, and ask them, which Medicare Advantage plans do you accept? Hopefully that will minimize the number of plans that you have to evaluate. Hopefully that just answers the question whether or not that's an option that is worth your time investigating. If your provider says, no, I'm not going to accept them, then you need to find a new provider if you want the Advantage plan, or you need to go with the original Medicare structure and address those challenges that can be seen in that. And when I say challenges, we're talking about premiums, certainly in particular that supplement premium, which can typically increase from year to year. So hopefully that answered the question. I kind of went off on a bit of a tangent there.
No, I think that's great information and information that we all appreciate. Thank you. Okay,
Yeah.
well, I think those of us we still have a good portion, most of the group remaining, and I think we really want to see what you have to show us.
Okay, so let's take a look at this, and I will try to keep it brief just to respect folks' time, anticipate maybe another 10 minutes of information here. So right now where we're at on the screen is Medicare.gov. This is the official U.S. site for Medicare. It does change from month to month in that attempt to keep fraudsters from creating scam websites, essentially. Very specifically, what I'm going to draw your eye to, what we're we're going to look at is this button, Find Health and Drug Plans. Find Plans Now. We call it the Plan Finder here in our office, and certainly Medicare sometimes refers to it as that, although not on their website for whatever reason. So you're going to enter your zip code as far as where you're at. I'm just going to go ahead and enter the standard downtown zip code. You do see that we have that opportunity to evaluate the Advantage plan, the drug plan, or even available Medicare supplements in the area. We're going to go ahead and focus in on the Part D for this particular portion because this is going to be a little more useful and really will be the same process you would utilize if evaluating Advantage plan options as well. So we're going to start with Part D, drug. When we click on Find Plans, we have this opportunity to tell the tool whether or not there are assistance programs in place. Maybe a person qualifies for Medicaid. If they do so, that can change how things work between Medicare and Medicaid. Most people probably aren't qualifying for that, at least people on this call right now. So we're going to just go ahead and address this demonstration as an average individual. Now, when entering into this, you do see that it's going to ask, do we want to see drug plan cost? We are definitely encouraging folks to check yes, especially if they have prescription medications. So once we click next, we're given this opportunity to either enter prescriptions, and you can start typing, and you see the tool is going to really start populating potential options based on what you've entered. You can scroll through, click on the drug that you're actually wanting to enter, and certainly we can click on Add Drug, but before I do that, I do want to show another option available. You see this Browse Drugs A to Z. When you click on that, you see this pop-up over here. And what this tool does essentially is it's going to show you every drug covered by Medicare that begins with the letter A. Apparently 252 drugs begin with the letter A covered by the Medicare program. I'm going to just pop down to V to make a point and to show that prescription drug plans, they don't typically cover vitamins and minerals. And a way to kind of verify that, we do see that there's a vitamin B12 here, there's a vitamin K1, but we see no indication of other vitamins. If a person were to choose this vitamin B12, it would be an injection. This is an injected B12. This isn't an oral tablet or capsule. It is, again, an injection. So vitamins can be covered, but in very specific situations, and only, again, as we're seeing, B12 and K1. So really this list is that way to kind of confirm whether or not something is covered by the Medicare drug plan. Look at that, 102 drugs starting with the letter V. That's just kind of interesting. But I'm going to go ahead and go back to this option of being able to just enter the drugs with this tool. Once you have the appropriate drug, you can hit Add. And what the tool is going to do is give you that opportunity to select the appropriate dosage. We encourage you to have your pill bottles with you so that you can just view that information directly from the pill bottle, or maybe ask your pharmacist for a printout if you don't want to carry the pills with you if you're going to an appointment with perhaps a ship counselor. Certainly the quantity is something that can be adjusted, and you would want to make sure you adjust the quantity based on the frequency. Typically, drugs are going to be distributed 30 for a month. So if you're a person who does a 3-month refill, if you were to toggle that over, you would want to make sure to change that to a 90 if it's a once daily, if it's twice daily, a 180, etc. You just want to make sure the math computes. Otherwise, you're going to get a skewed result. For consistency, I'm just going to go ahead and put everything on a 1-month basis for this demonstration. Once we know the information is correct, you can click Add to my drug list, and then we can start adding more drugs. I am going to add just a couple more prescriptions to make a couple of points. So the next one I'm going to enter is ibuprofen. And we're going to enter this at a 300 milligram extended release taken once a day. And then I'm also going to add a lisinopril just because. We'll go ahead and leave it at a 10 milligram. And 1, 2, 3, and one more. Now, this next one, I'm going to enter a brand name, and I'm going to enter the brand name of Effexor. Why I'm doing this is because I want to show what the tool does when you enter a brand name. You're actually going to get a pop-up that says, hey, Effexor comes in a generic form called venlafaxine. Do you want to enter the generic instead? Certainly, that might be an effective way of remembering what a drug is called if you don't remember the generic, or maybe you do actually take the brand name drug. In that case, you would click on keep brand if that were the instance. But in this case, I'm going to go ahead and just add generic. And one of the things why I use this drug is to also make this point. Note that the Medicare can show that there are several different available options for this drug. You see there's a 37.5 milligram capsule that's an extended release. There's a 37.5 tablet. There's a 37.5 tablet extended release. So these are those things that you really do want to take into account and make sure you're double checking your pill bottle or that prescription list. If you enter the wrong drug, you're going to get skewed results. Maybe see results that say this drug isn't covered. So that's why you really want to pay attention to these details. So we're going to run with these 4 drugs. I'm going to say that we're done. What the tool is going to do is it's going to allow us an opportunity to choose some pharmacies. And what I'm going to do is I'm going to choose 3. We encourage folks to consider the mail order pharmacy. Typically, this is going to be an option that will provide preferred pricing, but we also want folks to choose where they would typically go and where they would potentially consider going, maybe a local option. So for this demonstration, I am going to run with these 3 options. You see Walgreens, Kohl's, and the mail order pharmacy populated at the bottom. There is an opportunity to enter at least 2 more pharmacies if you wanted to. We're going to run with these 3. Now, when you click on done, what this tool is going to do is it's going to really actually kind of make a suggestion for you based on the cost and coverage of the prescription list that was entered. So the tool is going to sort these plans by the lowest drug plus premium cost. So of the 21 plans that exist in Nebraska, the plan finder is saying you might be most served best by enrollment into this Aetna plan called SilverScript Smart Saver. $5.30 is that monthly premium. It has a $280 deductible, but based on the estimates, this tool says that this person would only pay about $41 out of pocket. Now, what this tool is doing is it's essentially making an estimate of the first of next month through the end of the calendar year. So if a person were to enroll in September, this is October, November, and December coverage. Come October 1st, this tool will show you a full year estimate of 2025. And that's what our counselors are going to be using to help people make decisions for next year. So come October 1 through the end of December, you will have an opportunity to really get a view of what your full calendar year could look like using this tool. Note that the mail order pharmacy is about twice the amount, but that's probably because mail order pharmacies will send prescriptions in a 3-month refill. So that's probably a factor as far as why there's a difference in cost. Now, I'm going to put a little check mark right here, and I'm going to put a little check mark here because these are going to come in handy when I make a point afterwards, but I'm going to just leave that as it is now. What I'm going to do now is I'm going to take us into this plan detail. This plan detail is going to be the gut of the plan, if you will. It's going to give us some specifics, and the specifics include how much am I actually spending on drugs. We see that all 4 of the drugs are covered. $24.81 is that estimate. The difference of what we saw in that screen previously is the monthly premium over the remainder of the year added to that $24.80. As we progress down, we see contact information, a reminder of premium and deductible. We see the medication list that we entered. Everything is a generic at this point. As far as the pharmacy network, we see Walgreens is simply out of this plan's network. You would not want to go to Walgreens with this insurance. We see Kohl's is in network, and we see the mail order pharmacy is showing a preferred status, essentially potentially offering the best cost. Now, certainly if a person said, you know what, who else do I have available? They can click on this change pharmacy. And what this will do is essentially show all of the other pharmacies in the area with an estimate of cost. So we see this person could go to CVS Pharmacy as a preferred pharmacy and see an estimated cost there. But note that estimated cost is higher than what's shown there for the Kohl's pharmacy. This is why I encourage folks to choose more than one pharmacy. Truly, you are going to see that each plan, each pharmacy has a potentially different negotiated cost for the prescriptions. Definitely, you see that this map is something that you can navigate through and kind of utilize as well. I tend to just scroll through and use this option here, and certainly we can expand out. When I say expand out right here, you can filter for a distance of a 25-mile radius if necessary. I'm going to leave it where it's at, and I'm just going to go ahead and actually remove the CVS pharmacy because we don't need that in there because the couple of points I'm going to make, I don't want that in there to skew our results. So there is that opportunity to find other pharmacies potentially offering lower cost. What the tool goes on to do is they're providing a yearly drug cost by pharmacy. So if a person said, you know what, I really like my Walgreens, I don't care if my insurance doesn't work there, well, they're going to spend $508 on their generic atorvastatin, whereas they would spend $7.38 at that network pharmacy or nothing through their preferred mail order pharmacy. Certainly, if we would have kept that CVS in there, I suspect we would have saw these similar costs, if not lower, based on that quote we saw. Beyond that, the other drugs do provide that view of out-of-network costs versus network cost versus preferred cost. This is an example of sometimes a network pharmacy providing a lower cost than what a preferred pharmacy can offer. And we do see that demonstrated again there with the venlafaxine of basically a $45 difference between those. So this comes back to that question of convenience when we're evaluating the 3 Cs. Is it worth my convenience? Is it worth my time to utilize more than one pharmacy option? I've counseled people who say, I'm going to get these 4 drugs from this pharmacy, I'm going to get these other drugs from this pharmacy here, and then I'm going to order the rest of them from the mail order. Seems like a lot to keep track of, but that's what that person was willing to do to basically save money for themselves. Individual insurance, individual decisions. The Plan Finder tool goes on to provide essentially a look at the remainder of the year, basically providing estimates. Are you going to meet a deductible? Are you not going to meet a deductible, essentially? It also goes on to provide a view of projected out-of-pocket cost for the remainder of the calendar year, essentially. So really, we do see that this tool is, in a sense, providing a budget. And as I said, come October 1st, this will show the full calendar year. It's going to show January through December of 2025, really providing that opportunity to really get an idea of what one could potentially face as out-of-pocket cost from month to month. If you want individual cost breakdown, you can expand to these options here and get a view of what the negotiated cost is, what you're paying towards those costs within the different coverage levels. This probably looks familiar here. Deductible, initial coverage, coverage gap, catastrophic coverage. That's kind of what we're pulling towards when we show that visual in our slides. Certainly, you can expand this information to get more information. And what I'm going to bring us down to is that topic of limits. This is where you're going to find whether or not the plan imposes prior authorization, quantity limit, or step therapy. In these cases, you do see that the tool is saying that all of these drugs have a quantity limit of essentially 1 a day. If a person were prescribed 2 a day, well, the quantity limit would basically be something that may cause a person to say, I'm not going to enroll into this because it's affecting my prescribed therapy. Now, the final point to make here with regards to the information shown on the screen is the fact that you do have access to a star rating system. This star rating system is something that Medicare has put into place to help you be an informed consumer, to make a decision based on Medicare's oversight as well as feedback from those individuals enrolled into the plan. Why this is important to you is because a plan who earns less than a 2-star rating for 3 consecutive years, that plan is basically sanctioned and removed from being a plan provider of drug coverage. So this is that indication that you have, hey, is this plan going to be around in the next couple of years, or is this one that maybe has some opportunities that I don't feel like dealing with? That's what's great about having this tool in your hand is at your hand, essentially, to make some informed decisions with regard to how am I going to have my coverage provided to me in the future. Now, I'm going to just go back up to the top, and I'm going to click on this Change Drugs. And why I'm going to do that is I want to show you what happens when we kind of have higher drug costs. I'm going to enter in 2 drugs that's going to blow us up. The first drug is going to be a Humalog, and we're going to enter the brand name Humalog. We're going to make it the Quick Pen. They are getting the pack of 5 for a 1-month supply. And then I'm going to enter a Xarelto. And why I'm doing this is just to show that sometimes when we start adding the brand name drugs, things can really change. So initially when I did that, we are still within that same plan, the Silver Script Smart Plan, the $5 premium. Note that we're seeing a message here. 5 of 6 drugs are covered, $1,200 is that estimated cost. When we scroll down, Medicare does a very good job of pointing out what's not covered. So this insulin is not a $35 refill because it is not on the plan's formulary. If a person were prescribed this insulin and were interested in enrollment into this plan, they would need to essentially have a conversation with their healthcare provider to determine, is there another insulin that I can use that's as effective as this option that I'm using now? So that's one of the reasons why I entered this, is to show that messaging there. And another reason why I entered it is to show this messaging down here at the bottom. And that is just that view of the fact that the Xarelto cost, it does have that fluctuation. It does have some higher cost responsibility within this plan because the Xarelto, as we saw, is a tier 3. So a tier 3 drug within this tier 1, tier 2, tier 3. Basically, once the deductible is met, this person owes 24% of the full cost for the prescription. Very, very, very similar to what they would pay during catastrophic coverage, which is that 25%. So these low-cost premiums are really geared towards coverage of the generic options, whereas when we climb higher into the premiums, those plans are going to be more geared towards coverage of the expensive drugs. And what I'm doing is I'm going back to the full plan results to demonstrate that very point that I just stated. Once this loads, you're going to see a completely different plan being suggested at the top. We see it's a plan offered by UHC with a $103 premium versus the $5 premium. So essentially, why I put check marks by those other plans is I wanted to show you this side-by-side view. why a lower premium plan potentially is not something a person would just immediately want to enroll into. Certainly, side by side, we get to see the differences in premiums, the differences in deductibles. We get to see that difference in coverage. These lower cost premiums, they're not covering the drugs, probably the insulin, whereas the higher cost premium is covering everything, providing that lower cost estimate. So this is one of those reasons why, if you do have one of those instances where I forgot to enter something, you really do want to make sure you step back out and do a full reload so you can see, is there a different plan that's going to leapfrog the one that I was looking at previously. So again, if we add something, if we take something off, make sure to do a reload to make sure that we are actually getting the best results. And you see, I'm making it think, but that's what we want this tool to do. We want it to think. Really, as we scroll down, we know that the plan finder is suggesting the lowest cost, because as we scroll down, we just see these cost estimates really just increase as we go down this listing. So again, the tool is essentially doing the hard work for you, making the suggestion of the potential plan. So really, we did focus in on drug coverage. If you have that question about Medicare Advantage, you can toggle over, see those results there. But what I would suggest is doing some homework again, having that conversation with the healthcare provider to narrow down these options. Because if it's someone who lives in Lancaster County, you will find that there's like 28 different Advantage plans to evaluate and choose from. Have the doctor help narrow that down by letting you know which of those plans they accept. So we covered a lot there. This is what our counselors help people do. So again, if you didn't catch everything, if you didn't jot down appropriate notes, because we are going quite rapidly, note that the biggest takeaway, hopefully, is that you do have an unbiased source of information that you can work with and have this conversation. We are currently taking appointments for folks during the open enrollment season. Just as a reminder of what our program office does, is we are here to provide essentially, again, unbiased education regarding this topic of Medicare. Our services are free. Your tax dollars have paid for our program to exist. We all contribute towards this program existing. So utilize it. That's what we're here for. Do we have any final questions, Kelly, before we conclude for the day?
Jonathan, I don't see any more questions in the chat feature. Not at all. I have several saying thank you for today's presentation.
Thank you.
This was great. Thank you. I have several of those. And if you had anything you wanted to, any closing thoughts?
I do have one. If you don't mind this voice, we have a podcast. So What's Up with Medicare is a podcast that our program launched this spring. It is available on Broadcast House Media, iTunes, and Spotify, as well as a couple of other locations. The quickest and easiest way to find this podcast, folks, is if you go to our website, and the Google is a great way to find it, DOI, Department of Insurance, .nebraska.gov. If you go to that website, one of the things you'll see is a How Do I Learn About Medicare. When you click on that, it does bring you to an opportunity to basically access these podcasts. Currently, we have 5 or 6 episodes available. We release new episodes on the first Wednesday of the month, with the exception of October. Next month, we will release a week later, because the information that we need to discuss on the podcast is released that very day. Not enough time for us to actually evaluate and have an appropriate conversation. But I am a host. I do have have a co-host in this podcast, Jack Mitchell. You may recognize that name if you listen to radio here in Lincoln. But it is an effective tool and another tool for you to utilize in making decisions regarding your Medicare benefits. So just keep in mind that our program office, we do exist to provide as much education on this topic, and it is something that takes a little bit of repetitiveness to basically get under the belt. Let me tell you how many times I've said things before it actually stuck. So don't feel bad if you have a question that you need to ask more than once. That is common. It is a complicated topic that you're treading into, but again, the Nebraska ship, hopefully you find use in utilizing our program services. But beyond that, Kelly, very glad that you invited. We really do appreciate this relationship and opportunity to provide this education.
Well, we're appreciative of you as well, Jonathan, and thank you so much for your time today. Thank you, all of you who tuned in. Thanks to everyone for your great patience with us during our technical difficulties. Jonathan, I would never mute you on purpose. I just want you to know that your information is too valuable. And those folks who have registered for this segment, we'll be sending you our countdown to Medicare checklist. We also invite you to reach out to the folks at SHIP to utilize the tool that Jonathan showed us and to tune into his podcast. Also, tune in back here next Tuesday at 2 for the final segment of our Smarter in September series. It's going to be Smarter Right Sizing. We'll have some of our mortgage and real estate pros to show you what to do when it's time to move. Thanks so much, everybody. Have a great day.